Today I'm going to discuss how to perform the knee physical examination. First, we will review the knee anatomy and then go through the full knee exam. The knee is the largest joint in the body and is a hinge joint that moves in flexion and extension. The main movements in the knee occur between the femur, the tibia, and patella. The fibula is not part of the knee articulation. The four ligaments of the knee include the anterior cruciate ligament, or ACL, which prevents the tibia from translating forward, the posterior cruciate ligament, or PCL, which prevents the tibia from translating backward, the medial collateral ligament, or MCL, which resists forces coming from the lateral aspect of the knee, also known as valgus stress, and the lateral or fibular collateral ligament, or LCL, which resists forces coming from the medial aspect of the knee, also known as a varus stress. On the anterior view of the knee, you can appreciate the patella within the quadriceps tendon and the patellar tendon. In addition, on the medial and lateral aspects of the knee are the MCL and LCL respectively. On the posterior view of the knee, the ACL and PCL are visible crossing each other within the joint. This is a representation of the medial and fibular collateral ligaments. The MCL is a flat, broad ligament that is stronger than the LCL. The LCL is rounder and narrower, more like a pencil. The MCL needs to be able to withstand stronger forces because it is easier for the knee to be hit from the outside, producing a valgus stress. The contralateral leg helps protect the LCL from injury. The menisci are crescent-shaped pieces of fibrocartilage. They are made from type 1 collagen in comparison to the type 2 hyaline cartilage that makes up the articular cartilage. The menisci allow for correct weight distribution between the femur and the tibia, reducing contact stresses from a round femur articulating with a flat tibia. The vascular supply to the menisci is poor, only reaching the outer third. On the anterior view of the knee, you can see the medial and lateral menisci between the femur and tibia. They are again visible from the posterior view. This diagram shows how the menisci assist with weight distribution through the joint. The pes anserine bursa is located between the insertion of the MCL on the medial tibia plateau and the confluent tendon from the gracilis, sartorius, and semitendinosus. Also important in knee motion is the relationship of the patella to the femoral condyles. The patella is housed within the quadriceps tendon and glides smoothly along the femoral trochlea. When abnormal mechanics arise, the patella can be misaligned and glide laterally over the lateral femoral condyle. This causes a painful condition called patellofemoral syndrome. We will now discuss the knee exam. As with any other joint in the body, we examine the knee with the same systematic approach, which begins with observation or inspection, followed by palpation, range of motion, strength, and lastly the provocative tests. Let's begin with observation. It is important to observe the gait of the patient, looking for an antalgic gait or limp. Observe for scars from prior surgery or trauma. Bony deformities can be present, such as osteophytes. In addition, you can see a bow-legged or varus deformity, which, if not congenital, is usually the result of medial compartment osteoarthritis. A knock-knee deformity or valgus deformity can develop from lateral compartment osteoarthritis. The muscle bulk of the quadriceps muscle is important to observe, specifically the vastus medialis obliquus, or VMO. Quadriceps atrophy can be a long-standing problem from lack of use or can result after surgery. Other things to observe for are an effusion, erythema, and bruising. After observation, we move on to palpation of the knee. To palpate for an effusion, you can milk the fluid into the suprapatellar pouch and feel for a fluid wave. Alternatively, with large effusions, the patella will be ballotable. In this picture, you can see how the patient's right knee is fuller and there is fluid within the suprapatellar pouch. This video demonstrates how to palpate for a joint effusion. Milk the fluid up into the suprapatellar pouch and then compress the fluid down. An effusion feels like fluid under pressure. Okay, hit the red dot, and then the anterior palpation begins with feeling for tenderness over the medial and lateral facets of the patella, and then the superior and inferior poles. You can palpate over the medial and lateral fat pads and along the patellar tendon looking for tenderness. Other aspects of the anterior palpation include feeling the tibial tubercle for any tenderness or prominence that could be related to Osgood-Schlatter syndrome. In addition, you can assess the motion of the patella when the knee flexes and extends to see if there is any crepitus or abnormal tracking. This can go along with patellofemoral syndrome. Patellar apprehension test involves moving the patella in the medial to lateral direction, observing the patient's face for any signs of apprehension or the feeling the patella might sublux or dislocate. Finally, the patellar grind or quadriceps apprehension test is a test for patellofemoral syndrome. In this maneuver, you have the patient actively engage their quadriceps muscle, forced knee extension, while you push the patella down into the trochlea of the femur. Pain or apprehension with this maneuver is a positive test. This video shows the anterior knee palpation. Palpate the superior and inferior poles of the patella and then the medial and lateral facets, looking for tenderness. Move the patella medially and laterally and look at the patient's face to see if they are apprehensive that the patella will sublux or dislocate. For the patellar grind or quad apprehension test, first ask the patient to tighten their quadricep muscle. Then have them repeat this while the examiner presses the patella into the trochlea. Assess for pain. To palpate the medial and lateral aspects of the knee, it helps to have the knee flexed at 90 degrees. Medially, you can palpate along the entire medial joint line and over the medial collateral ligament. Don't forget to palpate over the proximal medial tibia where the pes anserine bursa lies. On the lateral knee, palpate along the lateral joint line and over the lateral or fibular collateral ligament. In addition, there is the iliotibial band, which is a fibrous band that originates at the hip and runs down the lateral aspect of the thigh. It inserts on the lateral proximal tibia at Gerdy's tubercle. With iliotibial band friction syndrome, patients can have tenderness all along the IT band and at its insertion. This video shows the medial and lateral knee palpation. Start near the patellar tendon and palpate along the medial joint line. Palpate along the medial collateral ligament and then over the pes anserine bursa. To palpate the lateral joint line, start near the patellar tendon and walk along the joint line. Palpate the lateral collateral ligament and then the iliotibial band as it tracks along the lateral thigh. In addition to the LCL insertion, the fibular head is also the insertion for the biceps femoris tendon. In the posterior knee, the popliteal fossa is a diamond-shaped area that is bordered superiorly by the biceps femoris muscle, superior laterally, and the semitendinosus and semimembranosus muscles, superior medially. The inferior borders are formed by the medial and lateral heads of the gastrocnemius muscle. When palpating posteriorly, you are looking for any abnormal bulges, which could include a popliteal artery aneurysm, a deep vein thrombosis, or a Baker's cyst, a cystic swelling arising usually from the knee joint. It is palpated more medially in the fossa as it is classically located between the medial head of the gastrocnemius muscle and the semimembranosus tendon. After observation and palpation, we will move now to the knee range of motion and strength. There are several ways to detect knee range of motion. You can have the patient lay prone on the table and look for a difference in heel height to see if there is full extension. Alternatively, in the supine position, you can check for knee flexion by measuring the distance the heel makes from the buttocks. Lift the heel off the table to assess for any possible hyperextension and then have the patient flex the knee. Estimate the angle to see how much flexion is attained. Full range of motion is from 0 to 135 degrees. You should always start with active range of motion, and if it is normal, then the passive range of motion should be normal as well. If the active range of motion is abnormal, then it is important to note what the passive range of motion is. Conditions with limited active range of motion but normal passive range of motion are commonly muscle weakness, nerve injury, or tendon injury. The most common conditions leading to limited active and passive range of motion are contractures from osteoarthritis. To measure knee strength, we will test the quadriceps and hamstring muscles. Have the patient sit over the edge of the table with their knees bent at 90 degrees. Ask the patient to extend or straighten his knee against your resistance. Then ask the patient to flex or bend the knee against your resistance. Compare to the unaffected knee. In the seated position, apply resistance while the patient extends and flexes the knee. We will now move on to the provocative tests. These tests assess the integrity or stability of the knee joint by individually testing each structure. We will first test the medial and lateral collateral ligaments using the valgus and varus stress test. Collateral ligament damage can occur with a varus or valgus force to the knee. To test the integrity of the ligaments, we perform these maneuvers trying to feel for opening of the joint. In the valgus stress test, one hand pushes the knee medially while the other hand is pulling the ankle laterally. In the varus stress test, one hand pushes the knee laterally while the other hand is pulling the ankle medially. In absolute full knee extension, where the knee is locked out and fully extended, it is difficult to perform these maneuvers due to the inherent bony stability of the knee in full extension. The knee should be flexed just slightly to unlock the knee and get a better feel for the competency of the MCL and LCL. The MCL is tested by pushing the knee medially and pulling the ankle laterally, creating a valgus stress. This is done again at 30 degrees flexion, which isolates the anterior bundle of the MCL. The LCL is tested by pushing the knee laterally and pulling the ankle medially, creating a varus stress. To test the anterior cruciate ligament, or ACL, we will talk about the Lachman and anterior drawer tests. This slide shows the sensitivity and specificity of both tests. You can appreciate that the Lachman test has better sensitivity and specificity over the anterior drawer, and the reason for this is the angle with which the tests are performed. The Lachman test is performed with the knee in 30 degrees of flexion, which mimics the normal anatomic alignment of the ACL better. The anterior drawer is done at 90 degrees of flexion. To perform the Lachman test, the patient is supine. With one hand you stabilize the femur, and with the other hand hold the proximal tibia with the knee at 30 degrees. Pull the proximal tibia forward to assess for laxity. The ACL should have a good endpoint where the tibia is not allowed to translate further anteriorly. The knee is flexed at 30 degrees. Stabilize the femur and pull the tibia anteriorly, feeling for an endpoint. If you have small hands or the patient's leg is large or heavy, you can perform the modified drop leg Lachman's test. Again, the patient is supine, but have them shift their position to the edge of the exam table. Drop the leg and place the ankle between your knees with the patient's knee flexed at 30 degrees. Use one hand to stabilize the femur and the other hand to pull the proximal tibia anterior. The knee is flexed at 30 degrees over the edge of the table. Place the ankle between the examiner's knees to stabilize. Then hold the femur with one hand while pulling the proximal tibia anteriorly with the other. While the Lachman is the preferred test, we will now discuss the anterior drawer test. The patient is supine with the knee flexed 90 degrees. Sit on the foot and place the hands behind the proximal tibia. Place the thumbs along the joint line both medially and laterally. Pull the tibia forward and assess for anterior displacement of the tibia compared to the femur. The knee flexed at 90 degrees and the thumbs over the joint line, pull the proximal tibia forward and assess for an endpoint. To test the posterior cruciate ligament, or PCL, we will use the posterior drawer test. The patient is supine with the knee flexed 90 degrees. Sit on the foot and place the hands on the proximal tibia. Place the thumbs along the joint line both medially and laterally. Push the tibia backward and assess for posterior displacement of the tibia compared to the femur. The knee flexed at 90 degrees and the thumbs over the joint line push the proximal tibia backward and assess for an endpoint. After completing the ligament tests, we move on to the meniscal tests. Besides joint line tenderness, there are two tests that can assess for meniscal tears, McMurray's and Apley's. As you can see, McMurray's test is not very sensitive, but it carries a very high specificity, indicating that when the test is done correctly and is positive, the patient likely has a meniscal tear. To perform the McMurray's test, hold the patient's knee with one hand with the hip and knee flexed at 45 degrees. The fingers are placed along the joint lines. With the other hand, cup the heel. Flex the knee, internally rotate the tibia and apply a valgus stress to test for the lateral meniscus. Flex the knee, externally rotate the tibia and apply a varus stress test for the medial meniscus. Continue back and forth like a pendulum to retest the medial and lateral menisci. Pain and a palpable click indicate meniscal damage. Extending the leg while it is rotated can help pick up posterior meniscal tears. The fingers are along the joint line. The heel is cupped in the other hand. Internally and externally rotate the tibia while feeling for a painful pop. You can add extension to try to catch a meniscal tear popping between the femur and tibia. To perform Apley's test, the patient is prone. Grasp the ankle and foot with both hands and gently flex the knee to 90 degrees. Push down gently while rotating the ankle back and forth. Pain along the joint line is a positive test. The patient is prone and the knee flexed to 90. Rotate the tibia back and forth to assess for pain in the joint line. This is a summary slide indicating the steps in performing the knee physical exam. This is an example of how to document the knee exam. You can create a knee exam template in CPRS and import it into your note. We hope you enjoyed this presentation on the knee physical examination.